Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 557 of our pharmacotherapy series, which majors in schizophrenia. What are some other adverse effects that should be monitored for in JPJ? Both specific to risperidone and for antipsychotics in general. Any patient receiving an antipsychotic should be monitored for all types of extrapyramidal symptom, including Parkinsonism. Other extrapyramidal symptom types, such as dystonia and akathisia, should be watched for, as well as the development of any tardive dyskinesia. Although the risk of these concerns is lower with an atypical antipsychotic, such as risperidone, it is still possible. JPJ's weight and serum glucose and lipids should also be monitored regularly, both during the initiation of antipsychotic treatment and periodically throughout. Risperidone also can cause drug-induced orthostasis, so she should be monitored for dizziness, especially upon standing. We will now focus on metabolic effects. Let's begin with hyperprolactinemia. Prolactin is a polypeptide hormone secreted by lactotroph cells in the anterior pituitary. Dopamine acts as an inhibitor of prolactin release in the tuberoinfundibular dopamine tract, which projects from the hypothalamus to the anterior pituitary. Blockade of D2 receptors within this pathway leads to increased release of prolactin and potential effects on multiple organ systems and gene expression throughout the body. Agents that cause more potent D2 blockade are associated with a greater risk of hyperprolactinemia. A multiple treatment meta-analysis by Lucht and Associates stratified select antipsychotics based on their effect on the standardized mean difference in prolactin from baseline as follows: paliperidone, with the highest, risperidone, haloperidol, lurasidone, ziprasidone, iloperidone, chlorpromazine, olanzapine, acinapane, quetiapine, and aripiprazole, with the lowest or decreased prolactin. Guidelines recommend baseline prolactin monitoring at the discretion of the clinician, screening for symptoms of excess prolactin at every visit for the first year of treatment and annually thereafter if symptoms are stable, and follow up prolactin levels only if clinically indicated. The upper limit of normal prolactin levels is 18 to 20 nanograms per milliliter in males and 24 nanograms per milliliter in females who are not pregnant or lactating. Clinical sequelae from excess prolactin release include sexual dysfunction, gynecomastia, galactorrhea, amenorrhea, hypergonadism, and potential bone mineral density changes with long-term elevations. However, prolactin levels do not directly correlate with these adverse events and patients may remain asymptomatic. Considerations for treatment should only be addressed in actively symptomatic patients. In symptomatic patients, dose reduction or switching to an agent with less potent D2 blockade would be recommended first line. If these strategies fail to improve the symptoms or cannot be undertaken for clinical reasons, a dopamine agonist, such as bromocriptine, cabergoline, or amantadine, may be considered. However, the risk of potential exacerbation of psychosis must be weighed against potential benefit. There is also growing evidence to support the use of adjunctive aripiprazole, a partial D2 agonist, to improve hyperprolactinemia in patients who cannot be switched from a more potent agent. Over time, JPJ's dose of risperidone is increased to 4 mg twice a day due to lingering symptoms. At one of her follow-up appointments, JPJ asks if it is safe to take the medication while she is pregnant. During the conversation, JPJ tells her psychiatrist that she is pregnant as she hasn't had her menstrual period in nearly 2 months, and her breasts have become larger and she has noticed she lactates periodically. The psychiatrist orders a pregnancy blood test which comes back negative, but her serum prolactin level is 115 nanograms per milliliter. What could explain why JPJ believes she is pregnant? The negative pregnancy test proves JPJ is not pregnant, assuming no error by the laboratory. Her symptoms are indicative of hyperprolactinemia, another potential adverse effect of D2 receptor antagonism from antipsychotic therapy. As her prolactin level increased, it caused JPJ to become amenorrheic and cause her to lactate. Although not a common adverse effect of most atypical antipsychotics, risperidone and paliperidone is similar to the typical antipsychotics in their propensity to increase serum prolactin. The next question reads, how should JPJ's hyperprolactinemia be treated? Ideally, the treatment of antipsychotic-induced hyperprolactinemia involves a dose reduction of the offending agent. As JPJ was increased to 4 mg twice daily due to an insufficient response to a lower dose, this may not be possible. If a dose reduction cannot be done safely, then a change in antipsychotic to one with a lower risk of hyperprolactinemia should be considered. If this too is not clinically appropriate for the patient, then addition of a dopaminergic agonist may be considered, such as amantadine. This should be done cautiously as a strong dopaminergic agonist, such as bromocriptine, may exacerbate her psychosis. There are also data available on using aripiprazole augmentation to treat hyperprolactinemia from antipsychotics, but this might be considered after other agents have been tried, unless JPJ appears to need a stronger antipsychotic regimen. We will now focus on weight gain. Although the development of the secondary generation antipsychotics was supposed to free us from the concern of the extrapyramidal adverse effects of the first generation antipsychotics, many of the newer agents such as clozapine, olanzapine, quetiapine, and risperidone showed a tendency to, like the low-potency typical first-generation agents, cause substantial weight gain. This substantial weight gain tended to occur to the greatest extent in the first few months of treatment, with a certain segment of those treated gaining more than 20 pounds. One study showed that 15.4% of those patients treated with olanzapine had weight gain greater than or equal to 7% of their body weight in the first 6 weeks of treatment. It soon became apparent that clozapine and these newer secondary-generation antipsychotics had the potential to increase body weight and serum triglyceride levels and therefore potentially cause glucose dysregulation as well. Patients suffering from schizophrenia are already prone to an earlier death than non-mentally ill patients due to their physical health and inherent sedentary lifestyle. Therefore, weight gain may be an even more critical issue than the potentially stigmatizing occurrence of tardive dyskinesia. Numerous mechanisms have been theorized to explain the weight gain induced by the secondary-generation antipsychotics. These include histamine 1 receptor antagonism, serotonin antagonism at 5-HT2C with a possible genetic predisposition in some muscarinic antagonism which could possibly lead to increased consumption of sugary beverages or thirsty calories, and impairments in plasma leptin secretion. Concomitant medications, such as valproic acid, lithium, mirtazapine, some antihistamines, and tertiary tricyclic antidepressants, can also increase body weight by synergistic pharmacologic effects. We will now focus on hyperglycemia and diabetes mellitus. It is unclear whether there are direct actions by second-generation antipsychotics involved in the development of diabetes mellitus. However, it is clear that weight gain, increased triglycerides, or decreased insulin sensitivity due to second-generation antipsychotics may cause an increased frequency or earlier onset of this endocrine disorder. An early study showed a moderate correlation, R equal to 0.6, with a p-value equal to 0.03, between serum insulin and clozapine levels, whereas Lund and associates showed an approximately 2.5 times greater risk of diabetes mellitus and hyperlipidemia in patients aged 20 to 34 years old treated with clozapine versus first-generation antipsychotics. Other retrospective studies in veterans also suggested a slightly greater prevalence of diabetes in patients less than 40 years old on the second-generation antipsychotics clozapine, olanzapine, quetiapine, or risperidone, odds ratio equal to 1.09, with a 95% confidence interval of 1.03 to 1.15. Than those on first-generation antipsychotics and an incidence of diabetes mellitus approximately 1.5 times greater in patients treated with olanzapine, risperidone, or quetiapine than with typical, mostly low-potency, antipsychotics. Guidelines stress the need to monitor these patients routinely for glucose dysregulation, weight gain, and hyperlipidemia. We will now discuss dyslipidemia. Treatment-emergent increases in both serum triglycerides and total serum cholesterol may occur with use of antipsychotics. The initial reports were of increased serum triglycerides with clozapine, a notation of this phenomenon in the package insert for quetiapine, and reports of this occurring in patients taking olanzapine. Risperidone does not raise serum triglycerides as severely as clozapine, and ziprasidone has negligible effects on serum triglycerides. Aripiprazole resulted in lowered serum triglyceride levels compared to placebo in pooled double-blind trials. Average serum triglycerides with clozapine, olanzapine, or quetiapine tended to increase by approximately 60 to 70 mg per deciliter between studies. Extreme elevations in serum triglycerides, that is greater than 1,000 mg per deciliter, have been noted in some patients and were often associated with acute pancreatitis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 558.